Hi, my name is Bari Platter. I'm really excited to be presenting at IntNSA's first global virtual conference. This session is The Nurse as the Patient, working with nurses in residential addiction treatment. I am a clinical nurse specialist and I work at CEDAR, which is the Center for Dependency, Addiction, and Rehabilitation. We're a division of UC Health, and we are located on the University of Colorado Hospital campus in Aurora, Colorado. We also have a campus in Boulder, Colorado. I'm going to be presenting, including all of my slides today for a 1-hour presentation. So there will be slides I won't be discussing in this session. Please feel free to contact me with any questions that you have, comments, or requests for resources by emailing me after you view the session. First, let's talk about outcomes. Today in this session, I'm going to talk about how the rates of substance use disorder differ in nurses as compared to the general public. I'm going to talk about risk factors that increase a nurse's chance of developing substance use disorder. I'm going to identify themes common to nurses and how these themes manifest in active addiction. I'm also going to discuss how group therapy and group programming specific to healthcare providers can be really helpful in the residential setting. So, if you look at all of the research that's been done looking at nurses and substance use disorder, typically you'll find that outcomes are that 10 to 15% of nurses will develop substance use during their lifetime, and you can see a breakout there of different specific substances. This is slightly higher than the general public. Similar to the general public, 50% of nurses with substance use report the use of multiple substances, and very differently than the general public, 14% of nurses with substance use report intravenous drug use, which is significantly higher than the general public. This slide was taken from a publication that was done several years ago. That was a guidebook for peer assistance programs working in alternative to discipline roles with nurses with substance use disorder. And these are risk factors that are described as ways that nurses become more susceptible or vulnerable to developing substance use disorders. The first is role strain, and role strain occurs when we are feeling overworked, we are experiencing burnout, or there is a sense of helplessness or hopelessness around making change in one's work environment. Problems of daily living has to do with chaos or dysfunction in the home environment. That could be domestic violence, that could be a divorce, or living with someone with a chronic illness, the death of a loved one. It can also include internal factors for the nurse, which would be negative core beliefs such as low self-esteem or a sense of worthlessness, insecurity, and poor coping skills. Also, isolation is a problem of daily living that's significant for nurses. One example would be an emergency department nurse that I worked with who, after working a night shift, she would stop by the liquor store on the way home, buy a case of beer, drink that case of beer, go to sleep, go to work the next day, and so forth. She'd pick up extra shifts, and gradually, as her addiction worsened, she lost all of her interpersonal connections with friends and colleagues. And by the time she came to treatment, was really all alone. Enabling by peers and managers happens when we overlook the symptoms because of misplaced loyalty to our peers or fear that our peer may lose her job. Managers may also overlook substance use symptoms in the workplace when that nurse is really important to the running of that floor or that organization. For example, we had a nurse that came in to treatment from a rural skilled nursing facility, and she had significant cirrhosis, jaundice, and pedal edema. She's also had an altered cognitive status. Her employer called several days after she was in treatment and said that she needed to return to work as quickly as possible because she was the only registered nurse at that facility, and they needed a registered nurse on site in order to meet state requirements for skilled nursing facilities. So this would be a way that a manager could overlook significant symptoms that a nurse has. Attitudes towards drug and drug use. There's this really interesting term called pharmacological optimism, which means that we are trained to believe that drugs work, and we see them work with the patients that we're working with. And so we can then rationalize that if they work for our patients, they will work for us. And that we are in some kind of way different than our patients or not susceptible to developing substance use disorders. So we can rationalize our use of those drugs in that way as well. In terms of lack of education regarding substance use disorders, I've found that it's very common for nurses who don't work in a mental health or an addiction environment to not really have much education about substance use disorder. In fact, in an expert training that I was in a couple of years ago, an advanced practice nurse with whom I have a very good working relationship and I have a lot of respect for her clinical expertise, stated that she didn't realize that if a woman was drinking 3 to 4 drinks a night, 3 to 4 times a week, that would be considered problematic drinking and probable substance use disorder. She thought that would be more social drinking. A lack of controls. Though we have really good systems of managing and controlling the use of narcotics in our hospital systems, there are many environments where it's easier for nurses to be able to divert controlled substances from those environments. Home care nursing would be an example, skilled nursing facilities, or other facilities where there aren't good policies in place. And then last, it says physician prescribing practices. I would change that to provider prescribing practices because nurse practitioners obviously can prescribe controlled substances as well. That we may, as nurses, develop relationships with prescribers in a way that they would feel badly in not giving us a prescription if we asked for it, or would freely give us a prescription to help with an emergency like an injury or insomnia or something else that needed urgent attention. And then they'd be culpable for providing medication inappropriately to the nurse. The next few slides go into more depth about each of these risk factors: role strain, problems of daily living, enabling, attitudes, lack of education, lack of controls, and prescribing practices. Let's talk very briefly about alternative to discipline programs. So every National Council State Board of Nursing has a disciplinary monitoring program. Some of those programs are directly connected to the state's boards of nursing. Others are more separated, and there's an ability to have confidentiality if enrolled in one of those programs. Only 73% at the time that I wrote this presentation of states have an alternative to discipline program in the US. A study in 2014 that was actually completed by the Colorado Peer Assistance Program from Colorado Peer Assistance Services showed that nurses in alternative to discipline programs are less likely to relapse and more likely to return to practice, and that the programs provide a wide range of interventions and advocacy and referral so that nurses are more easily able to return back into practice. The problem is that there is a wide variability in how each state's alternative to discipline program is set up. And so I think it's really important for us as nurses working in addictions to really learn more about how our state works with nurses who have substance use disorders, whether there's an alternative to discipline program, and how that program works in your state. In putting together this presentation, I started to think about common nursing themes that help us or support us in learning how to be competent, effective nurses, how we're socialized as nurses. The first is in academic and clinical achievement. We are rewarded when we have higher academic credentials and when we have demonstrated clinical achievement and received raises, bonuses, acknowledgement, rewards, statues at work. And so academic and clinical achievement is highly sought after in our theme, in our careers. We're also caretakers. So we want to take care of other people. We probably go into nursing because we were already caretakers, and this is socialized and reinforced for us. There are recognitions and awards that we receive for the selflessness that we show in taking care of our patients. Professional identity. You know, there was a study that was done several years ago that said that nurses, as they identify themselves with words, use the word nurse as one of the top 3 identifiers for themselves. So that I am a woman, that I am from Colorado, and that I'm a nurse might be the way that I identify myself. Leadership skills. We are socialized to become leaders, first in delegating to non-licensed assistive personnel, then to taking charge nurse roles, then moving into management. So wherever we find ourselves working in nursing, we are honing our leadership skills so that we are able to have things run smoothly in whichever area we find ourselves working. Pat Benner talked about imposter syndrome in her work many years ago, and this continues to be a common nursing theme, that there's something inside of me where I feel that I may not know everything that I need to know, that I'm really frightened about making a mistake clinically, and that in some way I'm going to be found out as being a fraud. So in active addiction, these nursing themes become distorted. Academic and clinical achievement can turn into perfectionistic behavior, or even using substances to enhance behavior, like using stimulants to be able to work longer hours, or using pain medication to push through when we're feeling pain and discomfort. Our caretaking qualities get distorted and turn into enabling codependent behavior, and we're taking such good care of everyone around us that we forget to take care of ourselves. Lacking self-care is a really common theme in active addiction for nurses. In terms of professional identity, that identity of self as nurse, in being proud of being a nurse and understanding what that means, turns into self-centeredness or grandiose thoughts about self, or can be turned into a negative way, where negative core beliefs such as I'm not good enough, I'm not worthy, I'm a fraud, I'm a fake, I'm going to be found out, becomes an obsessive thought that the nurse has. Leadership skills that help departments of nursing run smoothly are distorted in active addiction and can be seen in dishonesty and manipulative behavior and controlling behavior. And so the nurse that was very collaborative in her practice may be more controlling in her practice in active addiction, keeping secrets about herself or himself and being dishonest. And then finally, imposter syndrome. I talk a lot with my patients about a mask of competency or a veneer of competency, where we look good on the outside, but on the inside, we feel like a gob of goo, so that I may look good and I'm really not functioning well at all. We also can become workaholics in active addiction. Remember that addiction, according to the American Society of Addiction Medicine, is one disease that has different manifestations. So becoming a workaholic is a manifestation of the disease of addiction. We can also become, in active addiction, highly competitive and judgmental in the way that we work. So as we work with nurses who've come into treatment, what are our goals in correcting or adapting those distortions that became active during the time that substance use disorder was active? With academic and clinical achievement, we want to safely return nurses back to clinical practice, and we do that by coordinating with alternative to discipline programs or the state boards of nursing, depending on which state we work in. We help patients take care of themselves first. So we can't take good care of others at work or at home unless we're taking care of ourselves first. Our professional identity reflects balance in all aspects of our life. I teach DBT classes at Cedar, and one of the things that we talk about there is that it's important for us to create balanced thoughts, balanced cognition, and balanced behaviors and balanced actions. And so we want to have that balance in our lives in order to have a life worth living in recovery, as is stated in the Narcotics Anonymous basic text. In terms of leadership skills, we're helping nurses move from secretive, dishonest, manipulative, and controlling behavior at work to moving back to group leadership, to collaborative leadership, to sponsoring new nurses in recovery, to be a role model and to mentor new nurses. And then lastly, imposter syndrome. We help patients through therapy to let go of cognitive distortions using dialectical behavior therapy, cognitive behavior therapy, and other trauma-informed approaches to working with patients. We also help the patient let go of perfectionism, understanding that it's okay to make mistakes and to not know everything, and that when we let go of perfectionism, we have more satisfaction in the work that we're doing. So at Cedar, we have a nurse-focused treatment program that is part of our healthcare professionals track. It's contained within the program at Cedar. I'm going to move myself just a little bit. Okay, oops, backspace. Okay, the themes that we cover in that track for nurses and other healthcare professionals includes burnout, work stress, stigma, return to work, and trauma. We weave that track through our residential program, which is 30 to 90 days, partial hospitalization program, intensive outpatient program, in our outpatient addiction medicine and addiction psychiatry programs, which include medication assisted therapies. We also have a healthcare professionals aftercare group that I facilitate. It's a 1 time a week group therapy meeting for healthcare providers, and they attend for about 6 months to a year and beyond. I do have people that have been with me up to 5 years. While patients are in treatment, we complete psychological testing batteries. We have psychologists on staff that complete those. We We do return to work evaluations. We coordinate with the PHPs and the ATD programs in our state. And we also have many patients that come from other states, and we work with those states' programs as well. We also have a group on campus. It's virtual now, and hopefully will be in person soon. That's called Healthy Healers. It's a healthcare professionals peer support group. That's a generic 12-step fellowship group that's available to any healthcare professional or retired healthcare professional. They run that group very similarly to any 12-step meeting, and they meet once a week on the Aurora campus and once a week on the Boulder campus. That's been a really successful group, and the nurses and physicians and other healthcare providers find that it's really helpful to have an ongoing relationship with other healthcare professionals who understand the challenges and stressors of being in a monitoring program, of accountability, the high level of accountability that's expected, and the high level of care that they want to provide as professionals. So this was a whirlwind tour through how to work with nurses that are in recovery, working on recovery. If you have any questions or comments, need resources, would like to find out more about CEDAR, please feel free to email me at the address that's listed below. And I look forward to seeing you in the weekly panel. Thank you so much.